Good afternoon, ANCOR members. This is Donna Martin, the Director for State Partnerships and Special Projects, and I am really happy to welcome you to today's briefing on COVID-19, otherwise known as the coronavirus. We have some wonderful national experts, guest speakers on with us today, and before we get started, I'd like to just provide a few housekeeping notes. This briefing is being recorded and will be available on the ANCOR website, hopefully by tomorrow afternoon. Please remember to use the chat function on the bottom of your screen to pose questions. And for those of you who are listening in on the phone, please just send your questions via email to me, and we will address them in the frequently asked questions document that we are developing. And then we will be taking questions as time permits following the briefing from our speakers. And as I mentioned, we will develop an FAQ that will be available at the anchor.org, COVID page. It's anchor.org/COVID-19. And we'll get this information out to members as well. So with us today, we have Dr. Matthew Holder, MD, MBA. He is the immediate past president of AADMD. We have Diane Moore, BSN, RN, and certified DD nurse. She is the executive director for DDNA. We have Dan Berlin, director of federal policy from NASD's. Carrie McGraw, the director of communications and events at NASD's. Barbara Merrill, our CEO at ANCOR, and Shannon McCracken, our Vice President for Government Relations, also from ANCOR. So I am going to turn this over to Barbara now for a welcome and a welcome. Thank you, Barbara.
Thank you, Donna, good afternoon, everyone. On behalf of all of ANCOR staff and the ANCOR Board of Directors, I want to give a great big thank you to our speakers who are our partners on the line with us today, and to all of you who joined this call. Not surprisingly, there's an enormous number of you on this call, so please be patient if we can't get to your call today. So we're hosting this briefing because, like all of you, ANCOR is very concerned about COVID-19, the coronavirus, and its potential impact on our friends, our family members, our colleagues, and the people all of your organizations support and your staff. But we keep repeating, there is no reason to blow anything out of proportion. But as all of you know already, because this is your day job, the key is always to be prepared. You know, it bears repeating early and often, as long as it's applicable, is that the CDC states that most people in the United States face little risk of exposure. But our job here at ANCOR is to ensure that all of you receive the most up-to-date national information possible and to advocate on your behalf to ensure that our community is being included in all planning with the relevant federal agencies, including access to supplies, and to provide a nexus for member-to-member sharing, subject matter expert to subject matter expert sharing, state-to-state sharing. You know, that is a really unique platform that we have to offer to our members, and you're going to hear more about it on the call today. So for all these reasons, that's why we're doing this briefing. That's why we're updating our website to include a whole lot of resources, and we're going to keep it updated. And that's why we're extending our regular Friday membership calls by 15 minutes to be able to include the very latest information. Obviously, as you have come to expect from us, we will be sending out emails whenever there is news that can't wait to be communicated. We're also going to be sharing information and resources that our partners are developing. For example, we understand that NADSP, the National Association for Direct Support Professionals, is developing a webinar specific for direct support professionals to ensure that they're educated, that they're informed, so that they can effectively manage their jobs, as the situation changes, if it changes, just so that they are as prepared as possible. I think that's going to be a really good webinar. We're going to get that information out to you. Before I turn it over to Dr. Holder, I just want to share with you briefly about a phone call that we had yesterday with the CDC, the Centers for Disease Control. The call that we had was specifically with their staff that is leading the CDC's at-risk task force. We had 3 people on the call, including someone who was doing communications for them. We used the bulk of the call to educate them about our service delivery system, about our providers across the country, about the folks that you all support, about the incredible diversity of residential day and employment service models. And we emphasized, I think we re-emphasized, I think we probably said it about 4 or 5 times, we shared with them the magnitude of the direct support professional workforce crisis and how that could become potentially a huge problem, and that they needed to really understand that currently our members are having trouble filling the starting line, not to mention not having a backbench to support. The folks that we talk to, the CDC is huge. We learned the CDC has 10,000 folks. The folks we talked to were really deeply appreciative for all the information we shared with them. It was new news for them. It was important for us to communicate to them that that the folks that all of you are supporting are not in large nursing homes or, with very rare exception, large intermediate care facilities, but primarily in small community homes scattered across the country. So we think that was a useful conversation. We also spent time talking to them or urging them to communicate up that as the CDC coordinates with CMS, with HHS, with ACL, that they think hard about prioritizing our population as necessary. Examples, surgical masks, ensuring that there are adequate test kits available for our folks. So they took a lot of notes. It was the beginning. We are going to be staying in very close contact. We had invited them to be on this call, but they were unable to be at such short notice. But we have put up on our website all of the resources that they shared with us, and they shared that they are developing new stuff every single day. So there are a number of documents you're going to want to look at. Just because you looked at their website yesterday, that doesn't mean you're looking at the most up-to-date stuff. So that conversation was really a direct example of why I'm really pleased to share, to announce that we're partnering with the Partnership for Inclusive Disaster Strategies, NICL, the National Centers on Independent Living, and the World Institute on Disability, those 3 organizations, in a national call to action to urge the federal government to ensure that people with disabilities are included, meaningfully included in any and all disaster planning. And that disaster planning necessarily respects the civil rights of people while ensuring health and safety. So you're going to be hearing a lot more about that. We're going to be pushing that national call to action out. Some of you might have seen it circulating on social media yesterday. A press release is going to be going out. The tent is going to be significantly broadened, and as more stuff comes out of that, you are likely going to be seeing us urge you to take action where appropriate. So that's it for me. I want to turn this back over to Donna. But again, boy, thanks everybody, and we'll work our way through it, and we'll keep you informed.
Thank you, Barbara. Thank you for that overview of ANCOR's focus on work to support our members and the people that they support. At this time, we'll turn to Dr. Matt Holder. Again, he is with AADMD.
Hi, thank you, everyone. I'd just like to thank Donna and Barbara and Shannon for pulling this together so quickly. What a great response. For those of you who have been watching the news, of course, this has been all over the place. I guess the first thing I want to tell you is this is not the zombie apocalypse that's happening right now. When you watch the news, this is what some people are really panicking about this, and you hear things like, oh, this is a new virus, and a lot of people have never heard of the coronavirus. One of the first things I want to tell you is that the coronaviruses have been around for a very long time. You've probably gotten many of them in your lifetime. Most of the time it shows up like a common cold. This one is particularly bad. It's particularly nasty, but it is not, it is not an entirely new species of thing that's happening here. We hear a lot in the news about the mortality rate, and I kind of want to go over that a little bit because I think, and this is my personal opinion, but I think what we're going to see is a little bit of a decrease in this over time. But what we're doing right now is if you look at the CDC and who they're recommending gets screened and gets tested. So this is what's going to tell us, how many people there are who have the coronavirus. They're wanting to test people who have been in close contact with an infected person within the last 14 days, plus they have fever or lower respiratory symptoms like a cough or shortness of breath. Those are the primary symptoms that we're looking for with coronavirus, COVID-19, fever, cough, and shortness of breath. But they're looking for people who have had close contact. They're looking for people who have been hospitalized and have traveled to some of these geographic areas like China or Italy that have a lot of cases within the last 2 weeks, or people who have been hospitalized and fit these symptoms, but no other diagnosis. But what that tells you right there is 2 out of those 3 criteria are people who have been hospitalized. These are very sick people. So we're measuring mortality rates in a group of people that are already very sick, which I think kind of skews the numbers a little bit. That's not to say this is not, the mortality rates aren't higher than usual, but I think that we're going to see over time, if we're unable to test, quite frankly, all the people that are out there who might be exposed to this and really have no symptoms or just experience nothing significantly more than a minor cold. What I'm seeing right now when I look at the data, and it's really hard to keep up with this because things keep changing, but there's a recent study that was done on COVID-19 just talking about who gets infected by age and who gets infected and what the death rates are and what the mortality rates are. And with most viruses, and I think it's important to put this into perspective, the flu, just your standard flu every single year kills 36,000 people around that every single year in the United States, and we don't really think much of it, but that is what happens. We get millions of cases of somewhere in the neighborhood of 30 million cases a year. So the flu has about a 0.1% mortality rate associated with it, and typically it affects older people or people who are medically compromised in some way. So if you draw a line at about the age of 50 with this particular virus, what we're seeing is about 46% of people, of all the infections are happening for people under the age of 50, and about 54% are happening over the age of 50. So that's about the midpoint in terms of the numbers of people that are getting infected. But what's interesting is that under 50, the chance of mortality, if you go through all the weighted averages, is about 0.3%. So that's significantly lower than what's being reported. What we're being reported right now depending on the source, can be 2%, 3%, somewhere in that neighborhood. Now, if you look at the mortality rate of the over 50 population, that is about 4%. So it's significantly greater, and it really goes up as you get older. So the 80 plus population, they're looking right now at about a 15% mortality rate. But again, it's not necessarily just by virtue of the fact that they're older. This has to do more with the fact that they are, medically more fragile population. So I think this is important to think about with our population, because obviously we do have a number of medically fragile people that we work with. However, by virtue of the fact that they have IDD, that doesn't necessarily mean that they're at increased risk. If they're young and healthy and don't have a lot of underlying medical issues, they could be infected by this, and probably they're going to do okay. The transmission rate, or the transmission of this, appears to be respiratory droplets. So that means that it's sneezed, coughed, that kind of thing. It can be breathed in, inhaled, or transferred from, let's say, a doorknob to an eye or a nose or something like that by a finger. What we're hearing is that mainly it's going to be affecting people that are within close contact, so about 6 feet of somebody who's infected. As far as precaution goes, things that you can do, really, they're not calling for much else than what you would normally do to try to prevent any kind of flu or viral spreading. It's, a lot of us just sort of get lazy over the course of the flu season, especially when it's coming to an end. But these are the basic things you want to do. Wash your hands, wash them a lot. If you're going to cough or sneeze into your arm, use hand sanitizer. Disinfect high-touch areas like doorknobs, remote controls, iPads, video game controllers, bathroom surfaces, kitchen surfaces, things like that. Masks, for the most part, are not currently recommended unless you have symptoms. However, healthcare workers, they are recommended, and you can use surgical masks or N95 masks. Those are a little hard to come by right now. As you can imagine, there's a little bit of a run on supply, given all the news. And I would also just suggest that you make sure you have adequate stocks of soap and hand sanitizer and tissues and all those things that kind of help prevent things from being transmitted in a residential area. Another couple of things that you might consider is, of course, if you are sick, stay home. And I know this is kind of difficult for residential agencies especially, but it's probably the best way to stop transmitting a virus is if you're not in contact with a lot of other people. Also, I do some work with Special Olympics on the side, and I would also say that athletic activity is something you should probably stay away from when you're sick as well, any of our clients and such. And also, there are other things that you might be able to do. Consider things like having your groceries delivered instead of maybe going out on the outing, or watching home movies and having more outdoor activities if the weather's permitting. Those kinds of things. Those will just help decrease your overall likelihood of exposure. Really, we need to pay attention to the CDC, what your state health agencies are saying, what your city health departments are advising in terms of what needs to be done next. But the main thing is just to take those overall good practice precautions that we would use to try to stop the spread of any kind of germ. Just looking into the future, and nobody has a crystal ball. People ask me, what do you think is going to happen? How long is this going to last? And that kind of thing. Our first case in the U.S. was in January 21 of this year. Right now, we're doing a pretty good job of containing. I think the last I heard, there's 126 cases, I think, in the States. It could have gone up a little bit. I have heard models that would suggest that if this reaches into an epidemic level, and basically what an epidemic is a very rapid spread of the virus. Right now, we don't have that. We've got pretty isolated spread. But if we got into that, then we could expect a doubling of infections about every 6 days. What that would suggest is that it could take about 15 weeks probably for it to run its course. So we could be looking at probably on the outside 3 to 4 months if there happens to be a rapid transmission. I will say, if you look back at SARS, some of you may remember this way back in the early 2000s. It was a little different virus, and it was contained within China. But they took a lot of precautions, and even though there were transmissions for about a year, really once they started tracking it, they saw a dramatic decrease after about two to 3 months worth of time. And the other good thing, the good news is that weather, it appears, may be helpful to us. I've read at least one article that said that the virus becomes a little bit unstable at around 85 degrees. So that may be helping shorten what may be left of this cycle. So I'm just going to stop talking now, turn this over back to Donna, and I'll stick on the line for any questions at the end.
Great, thank you, Dr. Holder. And I just want to offer a point of clarification. I wanted to let people know that Dr. Holder is with the American Academy of Developmental Medicine and Dentistry. So he is certainly well-versed in our sector, as is our next speaker, Diane Moore, who is the Executive Director of the Developmental Disabilities Nurses Association. And Diane, please join in and bring us your unique perspective.
Well, hello, everyone. Thank you, Donna and Barbara and Shannon, for convening the meeting today. And I appreciate you including us and inviting DDNA to kind of participate in this. And I appreciate everything Dr. Holder shared. I think he provided some great framework as we look at how to address this from a facility perspective or a community-based program perspective, et cetera. Oftentimes especially in community-based settings, the nurse is the frontline person, the healthcare professional, and agency administrators and other personnel are looking to the nurse kind of for some guidance and direction and, okay, what do we do about this? So DDNA is preparing an official statement. We hope to have that out on Friday. So I'll be happy to share that with anyone who's interested once we do have that published. But our message is really first and foremost, and I think something Dr. Holder said is real important, this is a time to ensure that you're prepared, but not a time for people to panic. So we are looking to put just some guidance out to nurses that start with the planning phase, ensuring that your agency has a pandemic plan. What is the process going to be? What steps do you need to put in place? Making sure that your agency has that kind of outline of, okay, this is what we're going to do. And then obviously taking some of those steps to prepare for that, which is going to include obtaining or ensuring that you have protective equipment available and on hand in the event that you do need it. And as Dr. Holder pointed out, obtaining some of the N95 masks and even some of the surgical masks right now is proving quite difficult for most people. But again, some of the other things that rather than walking around in a hazmat suit, I think some of the lesser but more important day-to-day practices are real important. Hand sanitizer, making sure we're washing hands, making sure we're sanitizing surfaces, all of those things that he mentioned. We're also going to recommend that agencies kind of evaluate their current practice as it relates maybe to travel. Not that you do or do not need to make a change in that, but it might be something to consider. If you have individuals that you're serving who travel with their family or their family travels to internationally or to areas where we know we've got an infectious disease is going on, then what's your process when when the family comes back and wants to have contact with the person in service? It may be that you ask that the family limit their contact for 14 days, to telephone contact or something like that. The same thing with employee travel. Maybe asking your employees, particularly if we see a significant increase in the number of cases in this country, but asking those employees to consider limiting that travel, or at least informing you so that you can make an informed decision about whether or not the individual needs to remain away from work for 14 days or whatever your time frame is. So just kind of evaluating the agency's practices as it relates to that. One key thing that's critical, I think, is that all levels of employment, the employees, that they receive education and preparation. As Dr. Holder mentioned, there's a lot of information every time you turn on the news or open the internet. You're kind of bombarded, and I think it is raising concern among the general population and among employees as well. So trying to offer some measured and evidence-based information so that they can put all of this information into perspective and understand what their responsibilities are, both at their place of employment, but also how they can take that and carry that over in their own personal lives with their family members, I think is helpful. Again, immunizations, critical, making sure that the individuals that you support have their seasonal flu vaccine and other immunizations, and that your employees do as well, and as much as you can do that. So again, just some of the basic things that we may take for granted or may forget to really focus on as we have this novel situation that's developed. And then obviously the practice of our infection control measures, making sure that those routine practices are in place. And then there may be some enhanced measures that you want to take. Dr. Holder mentioned, sanitizing light switches and doorknobs and computer keyboards and those kinds of things. And maybe considering even, making sure that mail and packages are collected either with gloves or putting them kind of in a box for a day or two to make sure that any residual might be there. Again, that may be a bit beyond what's necessary at this point, but just thinking about those things. And then I think the other question that nurses are going to face is, okay, what do we do if we have someone who develops symptoms? And so this gets back to making sure that your nurse administrators are preparing your nursing staff for assessing individuals so that they understand what to observe for, and that those nursing personnel are prepared to identify concerning symptoms and then know what the next step is, notifying local health departments, etc. Another question is probably going to be raised about, do we try to create an area of isolation within the facility or the group home or the community-based home for the individual? And those are decisions that I think nursing administration and your local health department, as well as your primary care provider, all need to be involved in assessing the individual and determining whether or not they can be practically served and supported in that setting. And then obviously ongoing follow-up and review of the situation. If you might be that you want to have your plan kind of evaluated through your risk management team or through that risk management process, just to see if other people think of things that maybe you hadn't thought of or that you might want to consider. And then if there are no cases or symptoms identified, then maybe you look at that every couple of weeks just to make sure that all the pieces are in place. And obviously, if you have someone that's an identified case or someone that is symptomatic, then much more frequent, at least daily briefings with nursing staff and administrative staff to make sure that all the pieces are in place and that you're putting together the plan that's going to be effective in containing that and or controlling it, if you will, and certainly meeting the needs of the individual. So again, our statement is probably a little more practically geared toward those nurses, because oftentimes, again, the nurse is oftentimes the only healthcare professional for an agency, and so agency administrators and direct support personnel look to that nurse for guidance and information, and nurses need to be prepared to do that. So that is basically kind of where we are with this, and I'll be happy again to stay on the line like Dr. Holder and respond to any questions if I can. And I want to thank you guys again, and I'll turn it over to Donna.
Great, thank you so much, Diane. I want to take just a moment to ask our attendees that if you are using the Zoom platform and you have a question, please enter it in the Q&A box. You'll see that along the bottom of your screen. I think in the beginning I pointed you to the chat feature, but the Q&A box will ensure that we get all of the questions that are being posed. Sorry about that, any confusion there. At this time, I'm going to turn it over to Dan Berland and Carrie McGraw. They are both with NASDS, which is the National Association for State Directors of Developmental Disability Services.
Hi, yes, this is Carrie McGraw. I'm going to take it on first, and I wanted to provide another thank you to ANCOR for facilitating this important conversation. As mentioned, my name is Carrie McGraw. I'm the Director of Communications at the National Association of State Directors of Developmental Disability Services. If you're not familiar with our organization, we're an association comprised of the director and staff of the IDD systems in each state. My colleague Dan and I are here to provide you just a little insight into how we're supporting our members during this time. As an organization, we've been in frequent contact with our membership to provide resources and information sharing among the states and state directors in response to COVID-19. While we have been in individual contact with them before this date, our first mass contact with the states in regard to the virus was February 27th. Not saying the states weren't dealing with this before then, but that's when we addressed our membership. And we did that via an email to communicate to state ID directors themselves rather than the full staff of all the IDD systems. Via that communication and in preceding communications, we've encouraged our members to share their state's response to the situation in order to serve as both a repository and reference for all our member states. So we've asked them to share their general state response so that they can refer to how other states are handling the situation and learn a little bit further about best practices and share that information. We've also encouraged our states and our members to serve as a resource and a catalyst for their own state response strategies in order to ensure emergency preparedness communications are appropriate for the disability community and other segments of the population with varying communication needs. NASDS has provided the director's information on emergency preparedness offered in plain language, which is recommended for people with IDD, along with general resources in regard to universally accessible communication, which is really the preferred method for all public communications. As we know, the Americans with Disabilities Act provides non-discrimination protection for individuals with disabilities. And although the ADA does not include provisions specifically discussing application to emergency preparedness, its non-discrimination provisions are applicable to emergency preparedness and our response to those disasters. Several pieces of legislation also require states to put out information in accessible formats, not the least of which is the 21st Century Communications and Video Accessibility Act. It specifically addresses digital communication and its need to be accessible to all communities. NASDS intends to continue to support our membership in regard to providing accurate information on the virus and health information in universally accessible formats, including plain language, and are continuing to search out resources for how to do that for our members. NASDS has a director's call scheduled next week to provide further updates and more information sharing among our members, and we're hoping to have more to provide them at that point. On that call, we will offer greater specifics in regard to considerations for the IDD system itself in response to COVID-19. With that in mind, Dan Berland is here to provide a little further detail in regard to some of those specific considerations for the IDD systems when preparing for a situation such as COVID-19. Dan?
Thank you, Carrie. I appreciate it. And thank you again to the whole ANCOR team for pulling this together and for having us here. I'm seeing a few questions in the chat box and probably also in the Q&A, although I haven't opened that up yet, about what kinds of flexibilities the state might be able to offer to providers in during this, as the coronavirus might spread a little further. And so that's what I really wanted to talk about. And I just want to very briefly go through a couple of the different avenues that states have to be able to offer those flexibilities. So there's a couple different things that states will do if the coronavirus becomes more widespread, and in particular, if a public health emergency is declared. One of those is that states will be able to do Section 1115 waivers, and that's even if your state is not currently providing any services through a Section 1115 waiver. States can use Section 1115 waivers for emergency response. So we are advising our members to be at the table early because these are going to be broader than the DD system. These are going to be not only part of the affecting the entire Medicaid program, but also part of the state's broader emergency response. So we're advising our members to be at the table early in discussions with the entire state apparatus, but also with CMS and with the Medicaid agency in order to make sure that the needs of the DD system are on the table and to make sure that those are being considered. And so if the state is taking the avenue of a Section 1115 waiver request, CMS will be able to waive a lot of the parts of the process that can make that take a long time. That will include some of the things that often engage providers, including the state public notice and comment procedures in order to get that waiver through quickly. So that is going to mean that we would really like providers, of course, to be part of the part of informing what these waivers will look like, but that's going to mean that providers are going to need to be at the table as well. CMS there's also not a budget neutrality. Usually with 1115s, there's a budget neutrality requirement. In the instance of a federally designated public emergency, that requirement is also not enforced. And then the other pathway that a state might use to be able to implement some flexibilities to respond to a spreading coronavirus is in Appendix K of the 1915C waiver. So there's an Appendix K that is all about responding to these kinds of activities. So that would be more specific to each individual 1915C waiver in your state. And some of you may not have any 1915C waivers in your state. Again, you might be using 1115s. And some of you may have multiple 1915Cs that serve different populations. Some states have multiple 1915Cs to serve different parts of the same population. But in any of those cases, the state will have to have an Appendix K for each individual waiver. These can be completed retroactively if needed, back to the date of, they call it the event. I'm not sure what you would define as the event in this case, because we're not talking about a natural disaster, but they can be done retroactively. Some of the types of flexibilities that can be approached through an 1115 or through the Appendix K to the 1915C, you can look at changes to staffing ratios. I see that's a specific question folks have been asking, and it's obviously one that's on everybody's mind. Barbara, of course, mentioned the staffing crisis that we already have, and if we have staff that are sick, that's only going to exacerbate it. So changes to staffing ratios will be something that states are thinking about. Changes to rate methodology, especially how to deal with overtime if we're changing, if we're having staff working overtime to fill in for sick staff. Dealing with being able to provide services in alternate settings if we need to be able to have people who are typically receiving services in a setting like a group home or somewhere in the community, and that place is not available to them, to be able to receive those services somewhere else, or indeed to be able to receive services for a very short time period in an institutional setting when that's not where they usually are. And in an emergency situation, states can hold the waiver slot for a waiver participant who has a short-term institutional stay to make sure that they can come right back into the waiver at the end of that emergency period. And states can also use the Appendix K to be able to, for a very short period, provide some waiver services use 1915C to pay for waiver services in that institutional setting as well. So that's another flexibility that they may be able to look at. Also increasing the number of individuals served, creating new person-centered service plans based on the emergency, expanding provider qualifications, modifying service scope, exceeding service limitations that might be in the waiver, even adding new services to the waiver, even if they're not explicitly mentioned either in the waiver or even in the Medicaid statute. So there's a number of different permitting payment for services rendered by family caregivers or other legally responsible individuals that might not currently be part of the pool of staff that we're using to provide these services. So there's a lot of different flexibilities that are possible. It's going to be very different for every state. It's really going to depend on what kinds of priorities they pursue. And like I said, there's a couple of different sort of strategies in terms of what vehicles they could use to make those flexibilities possible. But we're going to be watching this very closely, and we really encourage providers to be in touch with the DD agencies in your states as well to make sure that all of the possible ramifications around a coronavirus spread are part of the conversation as states are pursuing strategies to be prepared in the event of a public emergency. So, and I'll be around for questions, and thanks again to the ANCOR team for having us here.
Great. Thank you so much, Carrie and Dan. That was really, really interesting and very helpful information. We want to take the next few minutes to provide some additional information, a little bit of recap. And we also wanted to share with you that yesterday we convened our state association directors to have some direct conversation with them about what are they seeing on the ground, what sort of assistance or guidance are they getting from any of their state offices, what are some practices that they're finding are helpful, and we wanted to just review that with all of you here. First and foremost, everyone that has weighed in, everyone that we're talking to really is obviously stressing the need for universal precautions, for good hand washing, good hygiene related activities. And we think that at the agency and the association level, this is a good time to reset your expectations around universal precautions. Maybe you double down on your in-service training for staff and the people you support on why universal precautions are beneficial and how that is the first best line of defense. This is also a time where we think agencies and associations can assist people with disabilities to protect themselves, helping the people you support to understand how do they keep themselves safe? Why are, again, universal precautions important? How can you put that in everyday language? This is an opportunity to really help develop some education and skill building for the people you support. And it's important that we make sure we have adequate information. And as I mentioned, information and instruction in real clear, understandable language. And to that point, ANCOR is developing a toolkit for education, guidance, and assurance. And that is in process now, and we will have that out to folks just as soon as possible. We are contracting with a self-advocate who is going to do a quick focus group to help really shape that message. And as soon as that is available, we'll get that out. We'll get that out to people via our website. Now, at the state level, I think Dan spoke to a lot of this. I think it's really important that we seek guidance from our state partners, particularly in the areas of program closures, quarantine measures, relocation activities. I know our state associations really talked about the need for some guidance around funding and billing issues related to program closures and quarantines. We had one state highlight the problem that they're anticipating around monitoring individual authorizations and those care plans being flexible to meet immediate and changing needs for individuals. And then throughout all of this, the need to remember the consideration of individuals' rights and choice. And we will build in some of that information into the toolkit, and it is one of the elements of the call to action that Barbara referenced at the top of our briefing. Another thing that I think Dan touched on that we wanted to suggest as a state level activity or a state level prompt in your state, if your state partners are not submitting information or pushing out information just yet, is the idea of requesting provider memorandums or other emergency regulation, other interim emergency guidance that they can offer that will help to create flexibility to meet rapidly changing needs of people you support. And then if guidance is still lacking, we would certainly encourage you to work with your state association on that outreach to your state partners. And then at the federal level, as Dan very adeptly described, there are emergency preparedness waiver options, one being an 1115 that would be applicable to all of your Medicaid populations within the state. And then there's also the vehicle of the Appendix K and the 1915C waivers. Now, we wanted to bring this forward. Obviously, that is not an activity that an individual provider or a state association could endeavor, but it is something that we wanted you to be aware of so that if you find your state is really in a hot seat, such as Washington State is, California State is really sort of experiencing an increase in cases at this time. We wanted you all to have the information that these are possible and available vehicles and methods to help address this issue and to help provide you with the flexibility and the resources you need to manage a crisis on the ground, so that if you're not hearing this from your state partners, you can ask those questions and you can bring that information forward. And with that, I wanted to invite Shannon McCracken, our VP for Government Relations, to talk about what ANCOR is doing in the immediate future.
Thank you, Donna. Hello, everyone. Thank you to all of our speakers today and for the hundreds of you literally that got on this webinar or this briefing that was planned very quickly. So I think it speaks to leadership at every level of the association and in your states. So thank you. Again, we wanted to just share with you overall, we want you to be prepared but not panic. And we hope to be that resource to you and a source of good quality, trustworthy information, and be here for you as we always are, but especially on this topic. And just to assure you, one of the ways that we are doing this is that our ANCOR staff, internal staff, is meeting daily on this topic, just even for a briefing to make sure we have the latest numbers and the latest news that we need to make sure that we pass along to you all or look for answers for you. Also, our weekly member briefing that we do every Friday at 12:30 Eastern Time. A lot of you participate in that. We will continue that at 12:30, and as usual, start off with our government relations updates. But we will be adding on an additional update and briefing on this issue. And Donna will probably be doing that as long as our team will cover that, but expect that beginning this Friday. If our GR updates are 5 minutes, we'll spend whatever time we need to be on the call after that, and we'll ensure that we keep the half hour open for that, for questions and any updates. Okay, we'll also be providing regular updates on our designated webpage, and it has been posted. We'll post it again. Oh, it's right there on the screen, but anchor.org/COVID-19. And then I just wanted to wrap my part up before we talk about questions to just reference back what Barbara mentioned about the national call to action. And in the spirit of giving you all good information, you know, really the quote I wanted just to reference from that call to action is, there's an urgent need for government to address the rights and needs of persons with disabilities throughout all COVID-19 planning and response. And we want to work to take action on that gap. Persons with disabilities require the same resources and assistance that everyone does, including adequate information and instructions, social and medical services, and protection from infection by those who have contracted the virus. So we take that call to action seriously and make sure as we're planning our response for you, to you, that we include those elements and keep that top of mind. Donna, I'll turn it back to you, or are we ready to go to Q&A?
We are. We'll
Okay.
go to Q&A.
All right. I'll do my best to manage through this. You've asked a lot of questions, and if you have, put it in the chat box. Make sure you pop it in the Q&A section, please. Okay, let's see. This may be for Dr. Matt, if you're still on the line. Is it too late to encourage flu shots?
No, it's not too late, although there may not be a big supply of them since flu season is kind of winding down. And of course, it's always good to encourage that, but I would just caution that the flu shot probably, well, it will not offer protection for this particular virus, but it does offer protection to 4 other viruses that are out there. So I think that's important to know.
Perfect. You answered another question as you did that, so thank you.
Sure.
Okay. And this one also is specifically to clarify something that you said, Dr. Holder, that it would take approximately 15 weeks to run its course. To clarify, is that 15 weeks from the initial cases or from when it reaches a pandemic, if and when it reaches a pandemic stage?
Well, that's sort of a mathematical estimate based on if we were to go epidemic right now with the current caseload that we have in the U.S., the known caseload that we have in the U.S. right now. So it's just an estimate either way, but you know, what all that's to say is that, you know, we're looking at a few months potentially, and that's assuming that it doesn't end up being contained. We could end up containing this thing and this thing's all over in a matter of weeks. It just sort of depends.
Okay, I'm just trying to run through these initially as far as the types of prevention questions. So Dr. Holder or Diane on the line, I think we could just run through these pretty quickly and then get to some different questions. Let's see, I'll save that one on staffing. There are a couple on masks in particular. So I know you talked about masks, but how would you suggest we receive training on fit for N95 respirator masks for DSPs?
That's a good question. I don't know that I have a good answer for it.
Hi.
I think the more difficult thing is getting the N95 masks. I know we've been trying to get some at our clinic, and everybody seems to be on back order at the moment. But I think maybe somebody else might have an answer to that question.
Okay.
Yeah, this is Diane. Your nursing staff, assuming that you have some available to you, should be able to provide that training to your staff. In addition to that, I think a lot of times on the packaging, there are actual pictures that kind of show how the mask is to be used. It is unfortunately, though, that kind of training is not something that you can just leave a written in service for staff. You would need to have staff come in and actually practice using those and applying them. And to Matt's point as well, the bigger concern right now is the unavailability of them. I know at my agency, we've been trying to order them since January the 12th and haven't been able to get any. We did have a small supply, but so I think that's the bigger concern. But if you do have some, I would suggest that your nursing staff should be able to train your direct support professionals on how to apply them.
Okay, a follow-up mask question. I think this is the last one. In the absence of a mask due to the lack of availability, is there a recommendation related to caring for a person who is symptomatic and not requiring hospitalization?
Well, Matt, do you want to try to take that one? That is a challenge. Or do you want me to?
Yeah, I haven't really seen any guidance to that. If they are symptomatic and not requiring hospitalization, probably the best things to do in that regard, well, you're going to want to try to limit exposure to the rest of the staff. So, I think, I don't want to use the term isolation because that's kind of the wrong term, but I think trying to just be extra vigilant about all the things that we talked about, cleaning up surfaces and, if the person, kind of minimizing contact with other people who maybe aren't infected or have not been infected. I would say if you've already had staff that already seem to have gotten whatever the patient has, then they could probably, they've recovered, then they would be okay to work with that individual. So that's something to think about is sort of natural immunity that might happen in staff who have already been infected, if that occurs.
Yeah, and this is Diane. One other thing I would add: if you don't have N95 masks, but you have plain surgical masks, you can have the person who's infected try to help that person learn how to wear that and have them wear that mask to help transmitting it, to help prevent transmitting it to other people. So while the staff might not have an N95, which is really what's kind of what the guidelines are, if the individual can wear a surgical mask, that would help with prevent some of that transmission. And then as Dr. Holder said, all of the other precautions, limiting as many people as you can, I would agree with all of that. And then hand washing and all of the other stuff that you can, that you would want to put in place.
Thank you so much. I'm going to consolidate a few of the questions. If you don't hear your question asked, we are capturing them all and we'll follow up in our FAQ, but I want to make sure that we give all of our panelists a chance to answer some of these specific questions live in this format. But the last thing, if I'll just ask if Dr. Holder, Diane, or one of you want to just talk about the vaccine that's in development, what you know about that, and timelines that's been asked a few times.
Well, Diane, you may know something about this. What I've read recently is that there are actually multiple efforts in multiple countries by multiple companies to come up with a vaccine. The only thing that I've read that had a timeline on it was something like a year out. So I don't know if anybody's heard anything sooner than that, but that's what I've heard. So it probably wouldn't be super helpful in this particular instance right now.
Yeah, that's the timeline that I've heard as well, is they're looking at 2021. I know there is some work on an alternative process that might offer something a little sooner, but I think Dr. Holder is correct that, we're not talking anything available 6 to 8 months anyway. So that's probably, and that's my estimation, but based on the trials that would need to follow anything that was developed, you're talking probably a year out would be your best case scenario.
Okay. All right. Thank you. Some of the next questions, set of questions relate to our service models and if people need to be quarantined. And Dr. Holder, you talked a little bit about that too, with, potential, or I forgot who did, I'm sorry, but talked about utilizing, some states may utilize open beds in ICFs that are not currently filled. We heard that one state is may purchase a hotel and put people there to quarantine. So this kind of goes out to different people, because it does speak to our staffing shortage. It speaks to, you know, how we possibly maintain business as usual if we're unable to provide and bill for some services and keep the lights on. So any thoughts specific on considering an in-place quarantine versus separate location in group home settings, for example? I know that'll depend on states in many chances, but anyone that would like to weigh in on that? I trust somebody might.
I think that Dr. Holder had to.
I'm still here. I was just hoping somebody else would answer it. But I guess let me just say, if you get to that stage, you're going to have a lot of conversations with a lot of people in your state about what to do. So I hesitate to even say what to do in that scenario, because my first step would be to call the health department or your state agencies, you know, and really talk it over with them, because if you have one of the first cases, they're going to want to know it, and you're going to do pretty much whatever they tell you. If you know, we're having a lot of cases and you know, there's thousands of these things, and you know, the plan will evolve, and so I think we just have to pay very close attention and contact the right authorities when we come in contact with something that we suspect is this virus.
Okay, thank you. Dan, a couple of questions for you specifically. First off, are there any suggestions for best practice in dealing with your members on this issue? What will they need or want from providers?
I don't know if Dan is still on the line.
I apologize if that question was directed to me. I was momentarily cut off from the call.
That's okay. I can read it again. I have a couple for you if you want me to put them back to back. The first one is, do you have any suggestions for best practice in dealing with your members, the state DD directors, on this issue? What may they need from us or want from providers?
Well, I think, you know, hopefully most folks on this call have relationships with their state agencies already, that you'll be able to, you know, work with them. I think that state directors are going to be trying to make sure that if this becomes an issue, so I want to make sure we're keeping in mind everything that Dr. Holder said about exactly what level of panic we should be feeling now, which sounds like not super high quite yet, no zombies on their way. But if this does become an issue, state directors will be trying to anticipate all of the various scenarios and issues that each of the providers and that the entire provider network is going to be dealing with. So they will be relying on open communication with the providers in the state to be able to make sure that they know what's happening and what you're foreseeing as issues. And they'll need to know as well, as you're starting to see COVID-19 spreading through the people you're serving or the people that are providing the services. That'll be something that will be really important for them to know as quickly as possible. So I would just say keeping an open line of communication and making sure that you're communicating with them the things that, the obstacles that you're foreseeing in terms of being able to continue to provide quality services.
Thank you. And I would just add that too.
Carrie, I apologize. I just wanted to interject also that during this call, CMS has issued a press release on coronavirus and some recommendations. I haven't had a chance to read it as I'm on the call and I'm also driving. But I just wanted to mention that it might behoove those on the call to take a look at it. there might be some additional information, obviously, that your state directors will be following and listening to, but perhaps we'll give you also some guidance in how CMS is approaching.
Thank you, Carrie. We'll also be reviewing that too. I
had another. Shannon,
oh, go ahead.
Shannon, if I could just jump in, this is Barbara Barrell. Thank you, Carrie. Yes, that email from CMS came in just a few minutes ago, and they've released 3 memos, and I've already shared with everyone in the chat one of the memos, which will be relevant to our members who operate ICF, because it is for nursing facilities, intermediate care facilities, and they're communicating. The CMS has made a decision to focus surveys on, procedures and protocols specific to infectious diseases, as well as, any type of an incident that, has the potential or puts anyone in jeopardy, abuse and neglect. So I think that everyone should read that. Even if you're not operating an ICF, I think you ought to take a look at it, because states might look at it for guidance for licensing regs and surveys for waiver homes in the event that your state does it that way. So yeah, thank you for bringing that up. I just wanted to share the 2 other memos, and we'll be sharing all of them, but that's the one at quick glance looked like it was the most relevant for our group.
Great. And then on that note too, just want to direct everyone to the CDC's website on their frequently asked questions. It answers a lot of the questions that you all are asking about symptoms and testing and things. So direct you to that just for their latest information. Okay, Dan and Carrie, a few more. Sorry, there's a lot. So let me scroll down here. Somebody asked for a link to the waivers and appendix that Dan referenced, and we'll ensure you get that as part of the follow-up to this call. 2 questions, other questions on that. I just scrolled past. I'll get it back. All right, here it is. Dan and Carrie, if your state waiver doesn't have a complete Appendix K to your 1915C, would they need to file an amendment through the normal and lengthy process, or can they bypass that?
No, they can. Not only can the state bypass that, but they can also complete the Appendix K retroactively. Obviously, if that's the approach the state takes, they're going to be communicating very closely with CMS to make sure that they're doing things that are going to be approved retroactively. But they're, whatever they need to do to make that move as quickly as possible, they'll be able to do, and then go through the process after the fact if they need to do that.
Okay, great. And also, what does quickly mean for CMS approval of an emergency 1115 waiver? Is there any recent history as a reference point?
I saw that question, and I was almost going to preempt it and tell you, I don't know. The most recent history that one might look at is around the time of H1N1, but not a lot of states actually did 1115 waivers based on H1N1, and a lot has changed since then. So it's really going to depend. First of all, just the staffing level at CMS in that particular part of the agency is different. And it's also really going to depend a lot on how widespread this becomes, how many states decide to pursue an 1115 strategy. So how many emergency 1115s on top of all of the other 1115s that they might need to be looking at, is that particular set of CMS staff going to have to be looking at once? So it's really hard to give an exact answer to that. But I will say, and I can't really quote an exact time frame of when how long any of the H1N1 things took. But I will say you're really looking at days, not weeks or months.
It's great to hear. Thank you so much. And there are other questions. I'm going to just put them in the category for our FAQ follow-up, but they are specific to what mechanisms are there if, there are issues with providing services in the traditional and allowed manner regulated by your state. And I think much of that is answered in what Nazis has shared with us today. So, okay, but I want to make sure we get through all the categories of questions. All right, let's see. Okay, Barbara, I'm going to shoot this one to you. At this time of year, there are multiple large conferences occurring all over the country. Are there thoughts about attendance at those types of conferences?
Sorry, I had muted myself. Forgive me. Thank you for the question. And I had actually intended to address this at the top of the hour. Well, ANCOR has a large conference 8 weeks from now in Miami. And you can bet that we have been monitoring the situation very closely. In fact, the CDC website has guidance, a document out specific for mass gatherings. And at this point, CDC is not recommending, canceling mass gatherings in places where there has not been any type of an epidemic. So we're in very close contact with our hotel in Miami and with the Miami-Dade County Health Authority. So we're not, at this point, we have no plans to cancel as long as the CDC continues to say that the risk is low for most people and there isn't an epidemic in Miami-Dade. However, obviously this is fluid. It could be fluid. And what is most important to us is the health and safety of all of you, for our staff, for the folks that you support and your staff. So if we learn different information, we will make that determination and we will communicate that to you immediately. Just to share, I was in contact with our partners, our disability partners at the ARC and the AADMD, UCP folks that are putting on a conference that's going to take place here in DC in just a couple of weeks. It's a disability policy seminar, and they met today and determined that based on the CDC guidance, they are not going to be canceling the conference. But obviously, all the usual precautions apply. If you know that you've been exposed, it would be prudent for you to not attend any kind of a mass gathering. We are, as I said, working with the hotel. We're going to make sure that we're doubling, tripling down on sanitation facilities at the hotel. But at this point, unless the CDC guidance changes, if you're invited to a mass gathering, I'd take a look at where it is and make a decision based on what you're comfortable with.
Thank you, Barbara. The last few questions really surround the same topic, so we will just include more specific detail in our FAQs, but I would just redirect you back to some of the comments that Donna made earlier about, contacting your state association. Some of the questions asked, how do I get to the table? Who do I contact at the Department of Health? ANCOR has a robust group of state associations throughout the country. If you email us at the ANCOR.org specific site to this issue that we have posted and keep repeating, you're welcome to ask questions about that too. And we can try to connect you to people in your state. But the state associations seem to have, they've developed the relationships with your DD directors, offices, and teams. And that's, in my experience, and I think Donna's as well, that's been a great way to ensure that your issues are heard, our concerns are voiced and addressed. Donna, do you have anything additional to that? I think a lot of the questions were around that, like how do we connect at the state level? Because it is very state specific
Yes.
in regards to the number of cases and the local, state, travel responses.
Exactly. Yes, I would just echo that, Shannon. And I wanted to let people know we've been giving you the full web address for our COVID-19 web page. But if you simply go to ANCOR.org, right on our homepage under latest news, there is a link to that section. We are going to continue to build out that web page with resources, with updates as we gather them. And there is a link embedded there to me for an email to me if you have specific questions or if you're looking for some resource or direction on an issue. To echo Shannon's point, certainly your state associations are a great resource and a great partner for you, but please feel free to reach out directly to us here at ANCOR, and we'll do what we can to help you get the information you need. I think that at this point, that wraps up our Q&A. We will have the recording and the slides available on the ANCOR website. Since you registered for this, you will get an email with a link to that. We should have it up by the end of the day tomorrow. And I want to thank our guest speakers, Dr. Matt Holder, Diane Moore, Dan Berlin, and Carrie McGraw, and of course, Barbara and Shannon here from ANCOR. We appreciate you all taking the time to join us today, and we will certainly keep our information as current as we can possibly get it. So with that, we'll end our webinar, and we will certainly talk with you soon. Thank you.
Okay, thank you, Donna.